Okay, we're going to get going. Hi, everybody. Welcome to QITalktime. I'm here with Dr. Philip Crowley. Thanks a million for joining us. And today's talk time, the fourth talk time in the WebEx series of QITalktime Autumn Winter, is on revisiting the framework for improving quality. So QITalktime aims to connect improvers across the country and allow for innovation and for local conversations in your organisations. So actually it would be interesting if you could type in the chat box function if you're in the room with a number of other people, just to let us know how many people essentially are logging in, to give us a flavour. So Dr. Philip Crowley, many of you probably know Philip. He's the National Director for the HSC Quality Improvement Division. Philip also worked as a doctor, as a GP for a number of years, worked in Nicaragua, he worked in the NHS, and he also worked in the IPH and with the ICGP on refugee and asylum seeker help. He worked for 6 years as the Deputy CMO with the Department of Health and continues to work as a GP part-time, as well as leading out on the quality improvement activities in the HSC. In order to take a strategic and sustainable approach to improving quality, the leadership team of the HSC has adopted this framework that we're going to bring you through today, based around 6 drivers. The framework is actually being used currently, and it's being tested in a number of different sites around the country. We just, somebody fed back that the sound was a bit low. We'll speak higher into the microphone. Hopefully that works better for you. So just some instructions around today's webinar. Just try to keep it as interactive as possible. We will have time at the end for questions or comments or anything that you want to ask Philip, and we'll also have Paul Rafferty joining us to do a little bit of a review of the framework for improving quality at the end. So any questions or comments, keep them coming in the chat box. The phone number is typed there if you wanted to jot that down or take a photo of it. Somebody has commented on Philip's November, so that's a good start. Thanks for that. So we will have time for questions and answers at the end, and we do have a very active Twitter site called QITalktime, so please do follow us and tweet any pictures of you in the room. Without further ado, I'm going to hand over to Philip, who will take us through his slides. All right.
Mason, thank you for those kind comments about my November. Great to be back actually delivering the webinar. I've been involved obviously in many of them and really feel that these webinars are part of a kind of a solution that we need in order for us to create this kind of movement of quality improvers. And I think what we will come back to at the end will be some thoughts around the new framework for skills for quality improvement. I think will start to help equip everybody to become improvers. So what about the kind of situation we're in now? I mean, my reading of where we're at and the context in which we're working is absolutely critical to all of our efforts to achieve improvement and better patient care. Demand is continuing to grow. You all know that. Anybody working in the front line can feel the pressure. Very adverse risk factor profiles in our population. We really need to get serious about prevention. Equally, at the same time, new technologies and rising costs, increasing complexity are leading to a situation where simply it's very hard to see how we can continue to afford healthcare delivered in the current way. So we can't keep doing things the same way. It won't be good enough. We have recruitment and retention challenges for our staff. We have staff survey findings, which I'll come back to, and we have a frontline that's under significant pressure with a very much a crisis orientation, which I think is inevitable. Recent research, I think, is worth reflecting on. It came out of the ASRI just very, very recently. Dave Van Ren led this research, and it gave a more stark view, I think, of where our population demand is going. Population growth of 14 to up to 23%, depending on inward migration of both people returning and new people coming to live in Ireland. Something between 640,000 to 1 million more people. More than double the number of greater than 85-year-olds. Care demand increasing by 54%, hospital demand by anywhere between 30 and 37%, GP by 30% or 27%. So demand is only going in one direction. So I suppose we need to start seeing that our services taking this kind of future scenario very clearly on board and starts to plan carefully for it. Part of our solution is the framework. We've discussed it before at a previous webinar, so I'm not going to go through the framework itself in any great detail, other than to say that the drivers remain the same. They're kind of obvious, I think, in many ways. Leadership is going to be critical, I think, for sustainable improvement, person and family engagement, staff engagement, and I'll come back to that particularly, use of improvement methods, having a way of getting things done, measuring for quality and for improvement, not just for pass, fail, and targets, and getting the governance aligned around quality. I think all of this will help lead our services in a more sustained and quality-focused way. So we've been applying it in a number of sites, Mayo, the National Rehabilitation Hospital, and University Hospital Waterford. We've also been applying it in the national collaboratives that we have on pressure ulcers and clot prevention. So, and also on work we've been doing in social care after hours Attracta. So, reflecting on those, it's early days, I think. In Mayo, they've been doing a lot of work on patient engagement, a lot of working on engaging staff from all disciplines and getting their governance right. So they've been attacking it through those three drivers initially. In the rehabilitation hospital, they've been focusing on a specific improvement goal to which the whole organisation is going to sign up to, and they've nearly decided on that. They're going to take a more organised approach to the many efforts that they already undertake on quality improvement. And they're having a major focus on having safety huddles to become more, if you like, mindful of the risks and ensure that they deal with those risks. And in Waterford, they've been focusing on governance and clinical leadership within that governance to focus on improvement and to get their measurement right. So they've been taking different approaches. And what we learned from this so far, I would say early days, true framework implementation really means that we would change the way we do things around here. In a fundamental way, and that's really changing the culture. This takes time. David Dalton, who's been over here, the CEO of Salford, one of the top performing hospitals in the NHS, went from being one of the lowest performing hospitals in the NHS under his leadership, and he undertook work around all of these drivers, but it took him 7 years. So it is a long journey, I think, for all of our services, and I think we need to be patient, recognize that, but also be urgent and press for improvement as soon as we can. Leadership and the approach to management is absolutely crucial, and I'll come back to that now in 1 minute. Here are a few of the products in Mayo. They have staff caring for staff and patient and family engagement. They've done a lot of work around that, and they've a lot of participation in those initiatives, and they're key drivers for improvement. In terms of the social care work, this just gives you a sense of the intensivity of kind of support that the team from the Quality Improvement Division that's partnered with the Social Care Division has given to some of the centres in CHO1 area, for example, where there have been some issues to deal with in the intellectual disability services. So it's the kind of improvement work we've been doing around the framework. It's fairly intensive, but they've achieved quite a few things. They've achieved, for example, in terms of the HIQA inspections, an achievement of standards rising from 43% to 86%. So I think the in-depth work that I've shown in the previous slide has led to a lot of work with managers to build and support leadership with clear aims and clear objectives, clear focus on governance, using the documents that we've developed around governance, focusing on the safety pause, and leadership walk-arounds for quality and safety. And then a big focus on engaging all staff. All of these things were totally absent in some of the services that were most struggling. So we found that the framework specifically addressed the major challenges in these services. In terms of the Pressure Ulcers to Zero, a collaborative which you may be aware of has been kind of rolling around the country. Basically, 50% reduction in pressure ulcers overall over a whole series of different sites. A lot of collective work using the model for improvement, but focusing again on the different drivers. So paying attention to the importance of leadership, engaging all staff, engaging patients in this as well, keeping the measurement going, and incorporating it into the governance. So the framework has been alive in the collaborative. Equally, in the collaborative on medication safety to prevent thrombosis, led to a very significant improvement in appropriate assessment, risk assessment, and appropriate prophylaxis in less than a year in 27 hospitals. Again, using the same drivers to try and drive that improvement. So leadership is at the core of it all. So I just want to say a little bit about leadership. John Fitzsimons gave me this slide. I think it's as good a definition of leadership as I've come across, and leadership means many different things to many different people. So for me, the leadership we're talking about is leaders who accept responsibility, not to do everything, but to create the conditions that enable others to do what they need to do to achieve a purpose that is shared and agreed, and in the face of uncertainty, because let's face it, that's what we live with every day, uncertainty. So that's just an image of leadership, if you like, in action. It's, including myself and Rosarie, everybody else are NPHD leaders. I used to be an NPHD leader myself. And they're part of a new cohort of leaders that we've been trying to develop to ensure that junior hospital doctors and non-consultant hospital doctors have a voice as well as other staff groups. A lot of evidence on leadership, and Michael West, who spoke recently at the National Patient Safety Conference, has just published, with other authors of the King's Fund, a review of the evidence on leadership. So this is the most up-to-date summary of what the evidence on leadership says, and it demonstrates a very clear link between a particular form of leadership, which I'll go on to now in a minute, and improved mortality, which is a very hard outcome, improved patient satisfaction, better financial performance, better staff well-being, and better quality of care. All absolutely evidenced in the literature, and this is a review of all the world literature. It promotes, the evidence promotes an approach to leadership that is really described best as collective leadership. So that's leadership for all. Everybody can be a leader in any given situation. Depending on what their area of expertise is, they can lead in that area. So what the evidence says is that leaders need to support staff, they need to be honest, they need to be fair, and they need to be optimistic. I think that's a challenge for us all, and I think we can see the sense in that, but the evidence shows that that helps create the environment where staff really thrive. All staff can accept their own leadership role, but we must allow them to do that. So leadership must be integrative as well across boundaries, so we don't just go into our silo and try and create great processes of care and leadership in that environment. We understand the importance of integrating care across boundaries, because our patients don't recognize boundaries. It needs to be driven by an inspiring vision, needs to be aligned to work at all levels. The vision needs to be, and needs to be based on effective teams. I'm not sure we talk enough about the importance of good teamwork, and teamwork is critically linked to better patient care and better outcomes. We also need stable leadership. We need to stop chopping and changing the whole time. And the best hospitals that they reviewed have very high staff engagement in decisions and a very distributed form of leadership. So that's the challenge to us all. And that is a big challenge in what has effectively been quite a command and control health service that we work in here in Ireland. So how do we get there? What's the evidence for how we actually create this type of leadership? Developing leaders itself is not enough. Just going out and skilling people up, that is not enough, and it is the approach that dominates in terms of leadership development. These leaders then go back to the workplace and experience the status quo. They can get worn down, and they can sometimes become, they may be ignored, and their ideas are not welcome. So to develop leaders all on their own and not take cognizance of the fact that it needs to be part of changing the environment in which we all work. So we need to develop the organization as well as develop leadership. And that's much harder. I accept that. But that's what the evidence says will work. So the context is critically important. So we need to change the context. We need to develop collective leadership in-house. So you don't bring people away all the time and work with them on leadership, but you need to go back to the site. And this is labor-intensive work to develop leadership of all. So everybody can lead in the areas that they're expert in. So bring the support to the site and have a key focus on organizational development. That's what the evidence says. So we would ignore that evidence, I think, at our peril. So what about our relationship with our staff? Some good findings from the staff survey: effective teams, happy with the standard of care they're providing, trusted to do their job. They can make suggestions to influence the work of their team, and they feel motivated. It's all good stuff. But really a call to action in there as well. Only 33%, and I would say this is the most important finding in the staff survey. Only 33%, given the evidence that I've just shared with you, only 33% of staff in our health service felt involved in decisions that affect them in their work. That has to be changed. We need that to be 80%, preferably 100%. Only 30% really felt valued, and that's linked to the earlier one, I think. Only 25% of confidence in decisions by senior managers. 45% said managers motivate them or have a one-to-one meeting, meaning 55% don't. 62% felt work-related stress, and 31% experienced bullying or harassment. That's a terrible figure. So we have work to do to change our relationship with our staff, and that means a new form of leadership, one that respects frontline staff and their own leadership. We've been doing a few things. The National Staff Engagement Forum, that's a picture from last year. They come up with this definition of staff engagement themselves. This is a cross-section of staff from across the health service. They say staff are engaged when they feel valued, emotionally connected, fully involved, enthusiastic, and committed to providing a good service. And when each person knows what they do and say matters and makes a difference. So in other words, people having a say in how things are done around here and then being able to act on what they feel is the best way of doing things in their area of work. So not kind of classical command and control and telling people what to do the whole time. So we've done another few examples. This is Tyrone Lance, who's one of the porters in Beaumont, and with some of the work we've been doing around working with emergency department teams to improve care and involve all staff in that. He led this piece of work with other members of staff, consultants, nurses, reception staff, etc., to look at the delays for patients getting wheelchairs, which delays turnaround time for ambulances and all kinds of things. They came up with a very simple solution and reduced the patient waiting time for this particular aspect of care by 93%. An extraordinary result led by Tyrone. We've been doing a bit of work with frontline ownership, which is effectively the same thing, which is basically involving all staff in teams in the front line to change things as they see fit. And we did that, we pioneered that in Kerry, and we use that learning now across the system. We've also been trying to show that staff are important in terms of short strands. Short strands are, they may not come to your neck of the woods yet, but they were, again, pioneered in Galway University Hospital and in the Blackrock Hospice. And I attended two short strands actually, and we brought them in. The Point of Care Foundation in the UK have the franchise for them, their US concept. I didn't know really whether they'd work here. I have to say I was absolutely bowled over by seeing their impact on staff, on just on morale, and we've been evaluating them, and the demand for them is now really exploding. There's a lot of evidence for them working in the UK and particularly in the US, where they've been in place for quite some time, and they work to improve staff morale and improve a sense of combined purpose and improve, I think, a kind of a sense of being valued, really, which I think comes to the core of some of those earlier findings of our staff survey. So I wouldn't underestimate short strands at all, and this is some of the things that people have been saying who've participated. They got an amazing insight into other people's and other professionals' experiences. It's amazing, you know, we can work in teams and not really know what other people do. They felt very glad that it was a very multidisciplinary environment, so all staff were involved. So it's not just nursing, it's not just doctors, it's everybody from the cleaner to the consultant, or from the consultant to the cleaner. They felt also that it broke down barriers between people, different members of the team, and it's amazing how many barriers can exist between people who, at least on the surface, if we work together to a common purpose. And it took, people felt fine. It took time out of the day. It's only 1 hour again at lunchtime, just very much like this webinar. They found it was a way of caring for themselves. And if we don't care for ourselves, the old adage, nobody will care for you. So we do need to look after ourselves to continue to do the kind of important purpose as well, but difficult and challenging work that we do in the health services. So I wouldn't underestimate the importance of caring for ourselves. And also people felt, you know, that really brought caring and kindness back to the fore and reminded, you know, people, I suppose, why they went into these caring professions in the first place. I'm sure we all can reflect back on our decisions to go into healthcare and why it was we went in, and sometimes we lose track of that, or we lose connection with it. And certainly I think people feel that Schwarzschild enable them to reconnect with the kind of fundamental reasons for going into a caring profession like we all do. It gave people, there's a lot of feel-good out of these interactions, and they found it quite moving and human, and so did I must say, in the two that I participated in. Found it a very moving experience. Talking about experiences of patient care or working in a team in the front line, and unpacking it and sharing it, and it's a very personal experience, one that is very, very rewarding, I think. And then finally, people found that it helped, highlight important issues, the importance, the impact of every individual, but not just the impact in how good we are at diagnosing illness or treating it or operating on people or whatever else, but also the simple things like showing a bit of compassion to our colleagues, smiling, maybe we don't all smile enough, and greeting people, the simple things that make a difference to people's working days, I think. So we've been doing some work around person-centeredness, which is staff-centeredness and patient-centeredness, in partnership with Queen Margaret University Hospital in Edinburgh. Brendan McCormick has been working with us to train up our own trainers in this as we become self-sufficient, and we're with 65 facilitators who in 65 different sites are working with groups of people to reflect on practice, to kind of explore and challenge our values and beliefs about person-centeredness, identify patterns in our practice that are based, as often our patterns of behavior are, on unconscious assumptions, expose those and then discuss them. And so it's not an entirely painless process, but one that's really quite profound in changing practice. And I've been to some of the sites, and this is one in Sheen, where Margaret Gorman is the head of catering in Sheen, and it's a centre that cares for older residents. And one of the residents' daughter was getting married, and they were just unable to go. It was too stressful for them to go to the wedding. They were too unwell, and it would have just created too many issues for everybody. So they couldn't go to the wedding. So the centre decided, off their own bat, to rerun the wedding in Sheen. And Margaret made this cake, which apparently was significantly nicer than the cake at the original wedding. And they had this great wedding in the centre with the residents and family. And to me, that's as good an example of person-centeredness as I've come up against. And that's the seeds that were sown 10 years ago in the training program, very much along the lines of which we're now revitalizing across the service at the moment. So we're trying to take this very seriously, and we believe it can have a very long-standing, sustainable impact. Doing some work around governance as well, because governance is a funny term, but really what it means is that the organizations have a proper focus on quality and improving care. And when I say quality, I don't mean just focusing on adverse events and reacting to all of that, but actually thinking our way through improving care, getting ahead of the demand for reacting to adversity. And so there's a whole series of resources on that, and we've done work with Temple Street Children's Hospital and Delta Group boards to try and really get the boards on board as well. And now we're working across the CHOs, the community health organizations, the National Ambulance Service, to make sure that they in turn institute structures that ensure that quality and safety is firmly on the agenda. At the base of all of this is measurement. You won't have gone to any improvement courses anywhere, I would say, without some discussion about measurement. And for me, working at the management team level and leadership team level and getting the performance report every month, I find we're dealing with a lot of very aggregated data. So it's hard to pick out the good and the bad in that, because it's a mixture of good and bad, so it's hard to interpret. A lot of it is point in time compared with, say, the same point in time the previous year, with a very solitary focus on targets. So we're not measuring things over time sufficiently, I think, to see trends and improvements that might be happening buried within data that's only looked at 2 points in time. So we're promoting the idea that statistical process control charts, which sounds very highfalutin and complicated. And it's a little bit complicated, but we have the technology, if you like, to help people develop these charts, and funnel plots which disaggregates data to let us see the good and the bad, and let the bad learn from the good, or the less well-performing learn from the better performing. We've also developed a measurement for improvement curriculum, national quality profile, which is something we're going to try and see if we can start to incorporate into the performance report. Social Care Division developed their own quality profile in partnership with us, and we have a whole series of resources and templates on that. We're still trying to continue to build capacity as well, to train people up. That's a very jolly photograph of all the graduates. In a diploma that we run in partnership with the College of Physicians, We've set this program because we believe that if we train as many people as we can, and we've trained over 250 people now, we can achieve a lot of improvements, because the projects that they do have achieved approximately, certainly over €1 million in savings, which is a lot more than we spent on the program itself. And we're up to cohort diploma number 14, which started this week. So we're plowing on with that, and we'll be doing a dedicated diploma for community healthcare organisations shortly in the new year, which will be very much targeted and focused on their needs. And at the base of that, and I'll bring Paul Rafferty in now in just one moment, we've developed something that we think is a resource for all staff, a knowledge and skills guide, which was launched now about 2 weeks ago. There, and I served my member on there as well, and there were 2 members of staff, and this is one more slide to go here. And we launched that to a lot of positivity, I have to say, and not everything we do is necessarily reach the level of positivity that this was. I think people really appreciate the idea that this guide is quite simple and straightforward. It's for everybody. It's also for people who move along the continuum of improvement, to go from being a member of a team to being a member of a team specifically working on an improvement project, to being somebody who champions improvement, like I do, to somebody who's like an advisor improvement like Paul, who's going to come in now in just 1 second. So there's different levels of, if you like, skills that we need to deploy in those different roles, and it lays them out. And Paul's going to show us how, in an interactive way on the web, you can access this guide. And it's not complete yet, but by and large, you can find some form of material or guidance or review that will help you go on a journey from knowing maybe nothing whatsoever about this to actually developing our knowledge and skills for everybody. So I hope that this is going to be something that's going to be very much welcomed, and we hope that the hospital groups and community health organisations and NAS use it to build the improvement capability within their organisations, because improvement has to happen everywhere. It's not going to happen nationally. We only help create processes that help improvement, but it's really at the front line that this would happen. So it's structured around the framework for improving quality. As I say, it's got numbers of levels of learning and development. You can decide whether you're confident in something, whether you need some development, or maybe a lot of development to be happy that you have the knowledge and skills needed. There are hyperlinks, which we're going to see now in 1 minute. And there's a personal development plan section that kind of aids your learning and development journey. So we'll be trying to populate this web-based version that Paul will talk us through now in the coming weeks and months. We've developed curriculum around it and training programs. So that's it for me for the moment, and we'll bring Paul in now to tell us a little bit about how it all works.
Okay, so while we're just pulling up the website, Paul, if you want to just give a little bit of an intro, and I'll pull it up here.
Okay. Thanks, Philip. So just a little bit of background. The QI division put out a survey to the system asking, what did they want from QID, and one of the strong messages that came back was they wanted guidance on what are the improvement knowledge and skills we want to develop. And so Philip was kind enough to ask myself and Paul Marley to facilitate the development of the guide, which we did with over 110 different members of staff and patients from across the system in all settings: mental health, community, and hospital. There is a booklet version of the guide, but we're encouraging everybody to use the web, because the web is interactive, and everything you need to know, I know we're kind of slaves to booklets, but everything you need to know is on the web. So this is the page. It's open to everybody, publicly available. You go into the HSC website and the QID section of that, and on the left-hand side, you'll see all the different things that are available from QID, and near the top there is the menu option for the Improvement Knowledge and Skills Guide. You click on that, and it brings you to the front page. And the front page just gives you an overview of the purpose of the guide. It gives an illustration of the different sections of the guide, and we got guidance that people didn't want improvement to be hierarchical or tied to people's roles. Improvement is for everyone. So the guide will tell you what are the knowledge and skills for everyone. If you're an improvement team, what are the additional knowledge and skills you need? If you're a champion, what you need? And if you're an advisor, in other words, an advisor is somebody who's coaching all the other 3 groups. The guide will tell you those kind of things. As Philip said, it's when you open up the guide, it'll ask you against each of the skills to say whether you're confident or you need some development, a lot of development. And a result of doing that self-assessment, there's a section which allows you to identify your priority areas for building skills and knowledge. So if you go down the website, you'll see the different sections. The first section here is the introduction. When you click on that, it gives you instructions on how to use the guide. And it'll also highlight a document that's about habits of improvers that's come from the UK. And the reason we included that is because normally when we talk about competencies, we talk about knowledge, skills, and values. We felt with the values program ongoing in the HSE, they didn't need another layer to talk about values, but we found this habits of improvers a really useful sort of checklist of what are the characteristics of people who are involved in improvement. If you go down, you can see the different sections. You can click on any of those. So I'm going to click on the team one. Hopefully it'll open up. Here we go. And here's the team section. All the other sections are structured the same way. The team section will give you knowledge and skills against the petals of the framework for improvement. So if you want to know what skills for a team are around leadership, staff engagement, personal family engagement, you'll find them then. So if you scroll down, you'll see each of the sections. So here's the leadership for the quality, and you're seeing suggested skills and knowledge you might need if you're going to be a team that's sort of leading improvement. And I'm going to drill down to the improvement methods. So here you can see, we think these are the kind of skills that a team that's working together to improve their service will need. You need to understand and know an improvement methodology. If you click on that link, it'll bring you to a document which will explain all the different types of methodologies that are available, be it microsystems or lean, etc. And you can choose and understand the difference between those methodologies. So if you wanted to know what a SMART aim is, for example, you can click on a SMART aim. If I click on that, it hopefully will take us to another website. So what we've done is for each of the knowledge and skills listed, we've created a link to a resource which will give you more information about that resource. What does SMART mean? The kind of sites we're linking to are internal HSE sites and also publicly available other sites such as the IHI website and quality improvement in Scotland and in the UK. So hopefully people will find it user-friendly. Again, you can select which part of the guide relates to you, whether as an individual or a team or a champion, etc. You go into it, you can click on the various skills, and on the right-hand side here you can see you indicate whether you're confident or need some development, a lot of development. You'll have to print this page off to tick the boxes. At the moment, the website doesn't allow us to make it interactive. And at the end of each section, as I said, you'll see there's a section down the bottom which is allowing you to list what are the areas of development you want to have. So we've got a lot of really positive feedback on it. I take the opportunity to thank the 110 members of staff who helped us with us at all levels of the organization, and just salute Philip and QID, who I think were the people who initiated something that I think is going to be hopefully very practical and useful to everybody. Yeah. Thanks, Philip.
Great, thank you, Paul, indeed. So I think that gives you a good flavour of that guide in vivo, if you like, rather than kind of just as it's much more than a document. It's a process. It's a whole series of materials and tools that hopefully will help people go on this improvement journey and help everybody to develop their skills around the system. Because one of the things we find working nationally is you can only be so effective working nationally if you have people to work with. And obviously the front line is a place where there's a lot of pressure on people, and it's quite hard for people to focus on improvement because they're so busy doing their day-to-day work. So it's great that, for example, people take lunchtime out today to have this interaction with us here, for example.
Great.
Any kind of questions?
Well, thanks a million to Eleanor Reebori, who's joining us from Canada, who is actually saying that she's sharing the document with her improvement colleagues in Canada, which is great. And Rose McCall is saying, you know, it's a great information to have at our fingertips, and especially for all those who are, you know, in training for competency-based interviews, it's a nice curriculum that you can use. So one of the things that I suppose struck me there is this could be daunting. It's a huge amount of petals and a huge amount of work that an organisation or a department is looking at implementing the framework. Where do you start? Where do you start with it? What would be your advice in terms of that?
Well, I'll let Paul come in a minute as well. For me, I think, where do you start? Yeah, I think you start where you assess what you're trying to achieve, and then you look through the guide and you try to assess, I guess, maybe get some advice as to how do I need to tool up to achieve what I need to achieve. It might be I need to, you know, get measuring something. Measurement is always a good start to anything that we do. And maybe I need to just look at, I'm going to lead something, we'll look down through the leadership driver. So I think you can start really where, wherever you feel your task challenges you most. That's what I would think.
And say, for example, if you were somebody working more at the front line who is really interested in this framework, but their leadership aren't engaged and don't particularly want to move in this direction, what would be your advice to those people? Well,
you know, a lot can be achieved bottom up, I believe. You know, I think part of what I sometimes feel is let's go away and improve what we need to improve ourselves anyway. If we can't engage senior management, let's prove what we're doing is valuable by doing it, by measuring it, by demonstrating it. That's a lot of what we do as a division as well. We measure, demonstrate, and then try and get people on board. It's sometimes hard to get people on board with something that may seem a bit theoretical. Once you start doing it, I think you're more likely to get management to kind of wake up to the potential for skilling ourselves up in this way and actually improving care, rather than just continuing to do things as we always have done, and achieving really the same results, which we know we all want to improve. I don't know if you have other thoughts on that one, Paul.
I would say the positive thing is, and I'm certainly meeting fewer and fewer people saying that anybody is resistant to quality improvement, and I think that's a credit to the initiatives you've sponsored, like the diploma. I think we're beginning to reach a critical mass. So obviously, people are very busy and there's lots of priorities. I think I don't see anybody being resistant. It's just how does it fit in to all the other stuff we're doing. I think just two things I would say is that I was inspired by Debbie McNamara and at that at Beaumont, and I hope she doesn't mind me telling this story, but Debbie came off the diploma in quality improvement and went back, and she sort of was waiting for somebody to do something, and it didn't happen, and she decided to do something herself. And from that, Better Beaumont has grown into something that is connected with a lot of people. So I know it's not the simple or easy answer, but I think individuals are providing leadership at any level to improve things. Again, I was inspired at the recent patient safety conference where one of the attendees of the microsystems course delivered by Lisa Toland, who's a member of your team, it was a porter who did a project on, and you mentioned that. So I think, I think the answer is don't wait. I know it's hard. I know there's lots of resistance, but those who are doing this are people who haven't waited and they've gone and do it. In relation to the guide, we were very clear that it needed to be simple because that's everybody said. And if you're going to visit the guide, go to the everyone section first and tick those boxes first. We've tried to, based on all the feedback, keep it as simple as possible. So, to be cliched, it's a journey, and just start at the very beginning and see what the everyone section says and see are those skills you need to build and take it from there.
Great. I have a comment from Kathleen Osborne from Galway. She's asking, from your experience in Galway and elsewhere, were the projects led out by the quality department? So she's probably asking in terms of implementing some of this, who leads out on it?
Well, I mean, I think Paul reiterated the example that I referred to earlier. I think anybody could lead out on this. And in terms of work we've done with Galway, a number of people from Galway will have done the Diploma in Improving Leadership improving quality. And they will have come from different walks of life. There'll be nurses, managers, doctors. But in reality, I think what we know is anybody can lead this. So I wouldn't be looking to any specific craft group to provide the leadership. If I wanted to do something and I was a radiographer, if I was working in the canteen, wherever, I could see something that would improve things. I'd like to think we can start to generate an environment in which people feel, well, I'm going to do it then. I'm going to make the improvement. And coming back to the earlier question, obviously, improvement really starts to hum, I think, when bottom up meets top down. But sometimes it just has to start bottom up, and then you start to engage the leadership, and then they start to really back it, and then you sustain it. I think it starts in the front line, though.
Yeah, and Ciara Kirk actually has just put in a few pieces acknowledging the Lunch and Learn success in Beaumont, but also leadership does involve a lot of pressures and responsibilities, and it's about doing what you can with colleagues from outside of your profession, those involved in processes particularly, and you can achieve a lot. Keep leadership briefed and supportive of you, and also keep data at the leadership table and progress. But middle managers and frontline staff usually lead the most effective improvement work, which is probably very true. Another question from Johan McKeever, he's asking about the sports rounds and how helpful are they in a small service where there are only a few disciplines working together, or is this a more larger system service, etc.? And great informative talk.
Thank you for that, Joanna. Well, sports rounds, in some ways, they're ideal in a small organisation. And the puzzling thing is they seem to also have an impact in larger organisations where you might think they might almost be like a drop in the ocean. Because you don't have a sports round with like 1,000 people at it, and there's a lot of staff in some of our bigger centres and hospitals. So, but they do seem to operate well in both types of settings. Different people filter through different Schwartz rounds, that not everybody goes to everyone. So there's opportunities for a wide range of staff to participate and to get some benefit out of it. We will be evaluating Schwartz rounds here in Ireland. We have a lot of qualitative feedback on it already, where people have said some of the things that I shared with you earlier on. But I think the evaluation itself will deepen our understanding of how they're embedding here and the kind of impact they're having. But looking at it internationally, it can have a very significant impact on people's sense of worth and value. Quite a few of the things I think that I highlighted that I was concerned about in our staff survey, they help address those issues.
Great. I'm just going to check here there are cost implications. Are there cost implications for organisations? That's from Mary O'Shea, yeah.
Yeah, I mean, the real cost implication for implementing something like Schwartz rounds is your time. We've co-sponsored with organisations participation in the training with point of care, and a number of organisations are going through that and will be setting up their Schwartz rounds this month. So they're starting to spread around the system. But the real cost of any of these things that we've talked about today is your time, which is really precious. I believe the early evidence in Ireland, and certainly the evidence internationally, is that the lunchtime spent in the Schwartz round, but more importantly the time spent by those coordinating and facilitating it, which is a bit more than just a lunchtime, is time very, very well spent. And we often worry, that we're too busy to do things, and we are. We are too busy to do many things that we'd like to do, but equally we're too busy not to do them. Is this flip side to that, and a lot of these things help create time and space in our heads to go about things a little bit more thoughtfully and carefully. A little bit like safety pauses. We don't have time for safety pause. If we don't pause and reflect and get a bit mindful about what's going on around us, we can blunder. We can make mistakes more likely in that type of environment. So it's up to us and to our managers working with us to help us create the time to do these very important processes that will improve our well-being and patient care as well.
And Eleanor from Canada just commented that it can be really helpful to think of the cost of not doing these things, which is very true, actually, yeah.
Which is, building on what I was saying. And Eleanor's been doing great work with us in Mayo, helping us draw on the Canadian experience of engaging patients in everything that we do.
Oh, so Maureen Flynn has just alerted us to actually there is an information day coming up on the 30th of November. She's added the link into the chat box there. So if anyone wants to learn a little bit more about it, it certainly would be worth your while to attend.
Yeah.
So thanks for that, Maureen. We've no further questions online, so thank you very much all for joining. Just to say, we do have a website on the HSE homepage, so just go to QITalktime, and all of the previous slide sets and recordings of the webinar are here. So if you're thinking about doing something with to do with the framework or the knowledge and skills guide, you'll have access to this to show your colleagues at a later date. Our next WebEx is on the 21st of November. It's Dr. Peter Lackman on Leadership for Quality. And if you want any further information, please don't hesitate to email myself, Roisin Breen at hsc.ie, or Naomi Palacios. I'll not try to pronounce that, at hsc.ie. So thank you very much, and hopefully we'll see you next time. Thank you.
Thank you.